All right. Hello and welcome to another Down Fracture podcast, a podcast for talking jaws. Downfracturepodcast at gmail.com for any topics that you would like to discuss, any cases you'd like to review, which is kind of what we're getting at today, Sam. This was a email requested topic that was on our list, but kind of maybe pushed us towards it and wanting to talk about dealing with vertical maxillary excess and needing a fairly significant impaction or vertical reduction of the maxillary position. Very long-winded way of saying, how are you?
I'm doing great. Only a couple more weeks in this year. How are you doing?
Hanging in there, man. You got family coming in or you're staying, right?
Yeah, we're staying. We just had some family in town. I think otherwise the rest of the year we don't. Do you have your wife's Christmas shopping done?
I don't even, this is a foreign idea to me.
Do,
What are you
do,
even talking
do you
about?
do you shop for your wife for Christmas? I assume you do, yeah?
Yeah, I mean, we do things where we try to make the focus on the kids so we don't do too much for
Yep.
each other, but a little bit. And, the kids want to get her gifts. And so that kind of falls on my shoulders as well.
Wife's always a tough one. I agree because you focus on kids and it's always like last minute in my world. So
I kind
two
of
weeks
just
before. I feel like I'm ahead of the game by even considering it 10 days before. It's pretty good.
knowing you, I would agree. I would also say, to an extent, I feel like when I proposed, like that was her gift in perpetuity. Like that
Uh,
getting to spend each Christmas with me is her real. My presence is her present, if you know what
yeah.
I mean. But for
Um,
whatever reason, she does not share that opinion.
I'm not surprised by that at all. So, well, great. Yeah. So, vertical maxillary excess. Yeah, I think these can be tough. This dovetails on the topic of maxillary interference management. But in general, BME cases, I think, are a satisfying operation, right? I think there's some that are a little bit harder to start off in. So if you're choosing some initial cases in jaw surgery, maybe staying away from widening both arches, doing TJR, revision cases. But impacting the maxilla, that's a good case. So vertical maxillary excess functionally as well on patient side to allow their lips to come together during the day and at night, help out with metallic strain. Those sort of things are nice functions when you meet people on the other side of big maxillary impactions. So this is a good surgery, I think. What's your take on it?
Agreed. I agree completely. And as we were talking just before we hit record, I feel like the aesthetic outcome is generally one that the patients are pleased with, even if you don't nail it. Like, we all want to get it perfect. We all want it to be absolutely ideal, but that's a tough thing to even get to because what is ideal tooth and gum show for me might be different in the eye of the patient, might be different for your eye. But generally, if you have significant excess and you show a lot of gum and tooth when you smile, talk, breathe, exist. And you can improve that fairly significantly, even if you don't nail it perfectly. I feel like patients generally view the results as favorable because it's such a drastic change for those that are so significantly vertical. And I find that they're usually very grateful, very pleased, very happy. And so it's a very rewarding operation in the aesthetic aspect in addition to the functional that you kind of mentioned. Do you have similar experiences with the aesthetics?
Yeah, I think you're getting on the right point, which is diagnosis is probably the biggest part of this in terms of picking up other reasons why people have excessive gingival show. Because people can come in with a couple different reasons for that, right? From
Yeah.
an absolute vertical position of the maxilla, the whole thing can be long. Anterior can be long, posterior VME can be long. Then there's upper lip short, upper lip hyperactive. AP position of the maxilla should not be forgotten in the consideration of vertical maxillary access because maxillary hyperplasia, so it's like bimaxillary protrusive, shows off a little extra gingiva. And so those considerations just kind of, pointing out a little bit of the obvious, but since we're talking about the vertical maxillary excess management on jaw surgery, looking out for other reasons of that are important. And I think gingival hyperplasia, I guess I didn't cover that, but
Yeah.
um, In my mind, this topic has more to do with very obvious clinically relevant vertical problem in the maxilla, such as, interlabial gap is a centimeter, rather significant mentalis strain, more gum than tooth show on smile, right? So kind
Yep.
of not 4 millimeters gingiva show, VME, more like 10 millimeters,
Yeah.
right? Yeah, like so when it comes to those sort of things, I think diagnosis is important because some of the fine tuning when it comes to the overall treatment plan has to do with the rest of that. So, um, you ever get a referral for someone with VME who needs a Lafort? Do you get that referral?
Yeah.
Um, what do you think? Is it easier to manage it with a Lafort or two jaw? How do you approach VME?
Yeah. I mean, I think as I said on here before, I tend to approach every case as a double jaw case from the beginning. Just patient education, insurance, planning for the worst. So I generally go down that path, and so for me, the answer to that question is I generally plan them as two jaw for most things. And then if when we really get down to it in the weeks right before surgery and we're doing the details of the planning and having that interview with the patient, getting their priorities straight, make sure we're on the same page. If I feel like it could be done with a single jaw, then we consider it. But generally, I find that these are better done with a two jaw. I mean,
Yeah,
I would throw that out there as probably true for most things too. But having the ability to change the occlusal plane or modify the occlusal plane or use the occlusal plane to your advantage, I think is huge. You're going to get with a significant vertical impaction, you're going to get some counterclockwise rotation of the mandible that I think you don't want to lose sight of from an aesthetic standpoint. So generally, I would say two jaw. If you're just focusing on fixing the occlusion, then yeah, often you can do most things with a single jaw. But I think to maximize
yeah.
form and function and all that aesthetics, you're going to need both most of the
Well,
time.
I mean, also, I mean, the people who have VME are generally high angle class two patients, like
Hmm.
I would guess that I'll meet a VME class three person, but generally those are short upper lips, with excessive gingival show. So, anterior open bite, high angle class two. If you do Lafort only, you're going to be moving the maxilla forward, which you're going to be chasing your tail on getting rid of gingival show. And it's also going to kind of put the face a little bit out of balance.
Yeah.
Um, have we talked about this? People look like Who's. Do you know, like the Grinch, the Who? Like they're maxillary protrusive in relation to the mandible. It's more the relative nature of those two bones, like too much clockwise rotation. Um, I had a patient mention that with post-op swelling, and she looked exactly like a Who. This was years ago, and it was she was laughing, her family was laughing. I couldn't help but laugh. But I do like that kind of visual, especially around this season, because that sort of thing comes up. But the chasing the maxilla forward on a VME case is tough just because of the underlying reason why it's there. Just because whether it's vertical growth pattern from condylar resorption, vertical growth pattern from core tongue positioning, mouth breathing type of thing. Um, it may look like it's just upper jaw, but most of the time, two jaw is going to be the right balance of things. So, um, and I think in that world, I know there's a group of people that like starting in the maxilla, but the longer jaw in significant VME is the upper jaw. And so I think doing the mandible first for the different reasons we've talked about, but then managing the maxilla is the right approach. Do you ever change
Yeah.
that?
No. I
Yeah, and
mean,
this one,
maybe, but that would be an exception that I guess I can't really think of much.
this is a subset that I think would be really hard with custom hardware, by the way, like patient printed, um, because the idea of splintless surgery that you don't have the teeth, you would need to hand impact the maxilla, right? So you would have to manage the interferences from the planned virtual plan, like the movement plan. But those tend to be pretty inaccurate. So you would have to feel it from just moving the maxilla up. So these would be hard, I think, with the printed hardware solution. So if there's anyone out there that only does that sort of thing, I have to believe it would be hard for this because having the feel of impacting the maxilla is very nice to know where to reduce the bone.
Yeah, almost the opposite of inferior repositioning of the maxilla, which you would generally think might be easier with
Yeah, yeah, like
patients
the
with some
opposite of
acute
that.
length.
I don't know, and I've never used it for impaction. It's just impaction. It's very much like because the bony interferences tend to be dependent on where the fracture propagates posteriorly and how much occlusal plane change you're doing and all that sort of thing. So, um, yeah, so I think from a planning standpoint, two jaw is going to be a helpful thing to plan this sort of thing out. So just make your lives a little bit easier by planning that part of it. Um, Vimy, are you changing anything in terms of your approach during the surgery?
I mean, I think we go back to our maxillary interferences, and yeah, you anticipate a lot more of those depending on where the movement is being impacted. I think I'm a
But
little more, what's that?
what do you use for reference markers?
Yeah, for me, I mostly use a K-wire, Steinman pin, whatever you want to call it, in the forehead, in the glabella. Is that what you mean?
Yeah. Yeah, because I
I
mean, some
was
people use like
medial
Canthus
canthus.
or
Yeah. What do you
um
use in pin, right?
what do I use? Oh, I
Yeah.
use a pen for sure. Yeah, yeah. Yeah, K-wire is great.
Yeah, that's what I was trained mostly with medial canthus, but I feel like that most of the time will work. It's just like you've got something protecting the eyes, whether that's tegaderms, tape, both. That feel like, it's very easy to have that be a millimeter, two, three off as things change throughout the surgery and making sure you're getting it in the right position every time. You're changing the soft tissues during the surgery. Um, I feel like a pen is a little bit more of an accurate thing, but a lot of people will just say I eyeball it.
Yeah,
And
I've seen that. I mean, I
and
think no
that's
matter what you do, there's going to be some inaccuracy in it.
yeah.
The eyeballing thing is tough though. Especially in a two jaw plan, particularly in the world of 3D planning. Just the predictive nature of things. Because if you
I would say I guess
overimpact, you
I
have
do a
more.
little bit of a hybrid. I mean, I guess I wouldn't say I rigidly stick to my measurements. There is some
Sure. Yeah, yeah.
leeway
No, I
in
understand.
eyeballing it. So yeah, I don't usually just raw
But do
dog eyeball it. Can I say that? Uh, Maybe I
I don't know.
should.
That's borderline. But yeah, I mean, it was said already, so I don't think it's making it through our
Yeah, we're not gonna.
extensive
Yeah. Well,
secondary
I don't
processing
just
process.
eyeball it in isolation, but if I do my measurements, I'm certainly looking to see if it makes sense. Like, was there inaccuracies in the plan? Was there inaccuracy in records? Like, if I'm planning a 7, 8, 9 millimeter impaction, when I do that, like, do they still look excessive? Do they look like they're not gonna have tooth show? And I'll modify it off of that, you know.
Yeah, I mean, I think that you can still use the other things, right? Like you can use technology to help guide it. Having a K-wire though is nice though, because you can have an external reference. You have a big caliper. You ever buy one of those big calipers, by the way? Um,
Not
those are
the huge
expensive,
ones, but
the
I
huge ones.
bought a caliper recently within the last year. What are
Like
the
and I forget how big they are. There's something like 6 centimeter or like 9 centimeter, like the big ones. Those are expensive instruments if people
Yeah.
are shopping for those things. Um, but yeah, I mean that gives you a reference. And I tend to measure, by the way, gingiva. If they have braces, I do bracket. I do middle, like the hook between the ones, um, because brackets can fall off, and rubber band and fixation material like wires can bend things. So like the bracket can move. And so I try to get a couple data points so that, left and right, just to kind of cover your bases in case, brackets fall off or something like that. But K-wire is not without trouble, like the length of it, why you want to use kind of a medium size is because it can be too flexible and the measurement process can bend the wire, making it an inaccurate measurement. I find how far out you measure on it tends to mess with the angles. It's
Yep.
pretty easy. There's like the reason why you choose central incisors, or the reason why I choose central incisors is because if I do canines, then like it starts becoming very angularly
Right.
different depending on how much the other dimensions the maxilla is moving. So as dead on straight vertical as I can measure. And I tend to measure that just because I know like I'll measure at the skin. There's not going to be much swelling in that area. Um, pull the lips out of the way so they don't interfere. It's just like any other measurement error. I feel like the the first time I used that as a resident, I didn't know how the caliper even worked. But it really is nice because you can get to, like 0.5 millimeter measurement intervals. So I feel like you can accurately measure it in that way. So I do.
Yeah, I mean, I would agree with you. The one thing I always wonder is, if you're changing the AP dimension too, like you're saying, it's difficult. I mean, you got to feel like that's changing it a little bit. Like I measure the same as you. If there's braces, I go between the central incisors and I push the caliper against the wire. I guess I didn't really I don't factor in as much of the wire bracket being altered by splints and other things like you're saying. I usually don't take that into consideration. But if I have braces, I shove it against the wire. And then if I am doing clear liners or just no braces, I do the gingival margin between the centrals.
Yeah. It's
But
just
if
sometimes
you're
hard to
bringing that
measure the
forward,
AP.
backward, like I always am wondering. I mean, I don't know that it's a drastic change, but that's got to weigh into the measurement there.
Yeah, no, I think little inaccuracies like that. I mean, like the wire bending can probably change a lot, or and not having a bracket can change it a lot. But little things like that probably are within the error of changing the vertical position anyway. Because I think, like you were saying, the absolute movement plan, let's say you're planning an 8 millimeter impaction, it may be during surgery that 9 looks like a better number, or 10 or 7. And I actually I do like having a little bit of flexibility in that. I still think that's the right approach. Because the AP movement plays into that. Their soft tissues play into that. Just the person plays into that. Like generally you want to leave people a little bit long, certainly plan them a little bit long. So if you're thinking they may need 8 or 9, stick to 8 on the plan. Um, that's a good rule of thumb.
Why
Uh,
is that? You've mentioned it here before. I know what you're getting at, but just
because
why do you leave it long instead
because
of error
doing
right?
a little bit extra impaction allows for a little bit more counterclockwise rotation. Chin comes forward. In a VME case, so high angle class 2, the inaccuracy of that plan is going to be less AP movement than planned. And so factoring in a little bit of a wiggle room for making up for that error is nice. And
No, I mean, I guess why, if you're going to make a mistake long or short, why do you want to leave them long?
for that reason.
Like, why would you want them to have a little bit of vertical maxillary excess instead of too much impaction if you were going to like err on the side of one or the other? I thought
You mean in
I
terms
thought that's
of,
the point
I'm just
you.
speaking of the plan, not during surgery. Yeah, the plan,
Yeah.
you want to plan them a little bit longer so you have wiggle room. But like during surgery, you want to leave them a little long just because the healing process is going to move them up. It's a stable movement. Impaction of the maxilla is stable, so it tends to stay in the same position. But the general tendency is to keep people looking young, showing a little bit of gum. Um, Soft tissue is biased in a way to where it's always a little bit more impacted than intended. So
Yeah, I mean, I think the other things that I was thinking, and you weigh in on your thoughts on this too, is I think it was you who's mentioned that on here. I can't remember which one of us talked about it, but generally when people smile, like there's degrees of animation that you do have a little bit of control over as well. So like if
yeah,
you're way
that's true.
too impacted, you can't like smile and show enough teeth. But if you show a little bit too much, you can train yourself to not smile fully and show as much. And then age, it's generally going to decrease with time, like you were talking about,
Yep.
giving people a little bit of a youthful look. But you're doing this in a young person and you leave them with a little bit of excess over time, the lip's going to kind of move down and maybe become more aesthetic over time. I guess that's what I was getting at.
Yeah, yeah. No, I agree with you. Let's see. With the nose, you do anything different with the nose? Same,
I don't
same,
know that I do anything
everything.
different. I mean, I think you just plan on more either septal reduction directly. These are the ones where, I tend to groove out the nasal floor as a routine protocol in my Laforts. But this is one where if we're doing significant movement, then I would maybe, take the freer and try to separate the septum from below and actually trim the septum to make sure I'm not getting interferences there
Yep.
uh, based
Yeah, and
off
that
move.
the planning part for the counterclockwise rotation really helps out with that because most of the nose work is anteriorly.
Yep.
You ever partially reduce turbinates? just
Yes.
purely?
What do you, well, let me make sure I understand what you're saying. Like, I don't always take them out completely. Sometimes I just crush them. Sometimes I just take out a little bit
Sure.
and not the full thing. Is that what you mean? Or what are you
Yeah,
getting at?
just like yeah, I would say modifying the technique. I mean, obviously taking out the whole turb doesn't need to happen too regularly. Um, but I mean, potentially in big impaction cases, right? Like, I mean,
Yeah.
if you're going up 12, 13 millimeters, space underneath the turbinate might be a millimeter or two. So there isn't much else you can do in that scenario. But if it was somewhere in the middle of that, let's say the anterior maxilla is moving up 7 or 8, you can take away bone from that area for quite a bit. And like your X-ray that you have up, I mean, you have a centimeter of bone that you could remove there. And I'd be much more partial to taking away the bone than I would be taking away the turbinates. It's just that that anterior maxilla is different than the palatal bone. And once you start transitioning to the palatal bone, if you're not widening things, then you only have a few millimeters depending on the anatomy, maybe 2, 3 millimeters in that area that you can take away bone to just kind of run out,
Right.
and you have to do something to the turbinates. And so reducing the anterior part of the turbs, the nasal tube will make the turbs seem worse than what they are. But subtotal removal I think, is a good trick. So
Are
I
you saying, like, looking at my screen, you're saying you would take like the oval burr and like burr this kind of area down, like on either side of the septum, and even take it a little bit further back or posteriorly? Is that what you're getting at?
Why wouldn't you just take all that bone?
Yeah.
Let's say you're the maxilla impacted 8 millimeters in the surgery you're showing. Why not take away 8 anteriorly from the
Yeah.
bone? Yeah, I mean,
Yeah.
it's great bone you can recycle. That bone's great in the mandible. It's great in the posterior maxilla if it's moving down a little bit. That's bone I tend to borrow anyway in most cases.
I
But
will
in VME
generally
cases,
burr out the septum, do whatever I need to do with the spine, and then I'll kind of take this down in my impactions. Is that
yeah, and
something?
I've seen this like dictated as a separate procedure in different people's notes where they're harvesting bone from the anterior maxilla.
Hmm.
I it makes me think that that's not a routine thing for people. I think if there's roots there and there's no bone, but that is a lovely place to harvest bone from. You take an egg burr just under like moderate amount of irrigation, it creates good bone dust that you can populate your cadaver bone in. And you can create that bone dust from, channeling the nasal septum on the floor, the nasal floor. But this anterior maxilla, the X-ray that you have, you can borrow bone for days from that area.
Oh
So
yeah.
that'd be great.
Yeah. You, I mean, like you
Um,
said, you got to be careful of roots. You got to leave room for fixation, but usually
Absolutely.
not an issue in that right immediately lateral to the midline. Yeah.
Yeah. Yeah. And so designing it a little bit is useful from that standpoint, just so you can leave space on the canines. So if you make your cut a little bit higher, so you can just still get fixation above the canines, but harvest a lot of bone is nice. Every once in a while in a VME case, the other thing has to do with fixation. Um every once in a while you can just use positional screws in the maxilla. Um and then the maxilla seems to be going backwards. So I think fixation tends to be the other weird thing when it comes to VME cases. You ever just positional screw?
No, you're like talking about not using plates. You just do.
Yeah, like it's telescoping.
No, I don't think I've ever done that.
Yeah, positional screws, I mean, they work in the maxilla like they do in the mandible. It's just that it's pretty unusual for that fixation to be possible. But when that is, it's generally because the maxilla is going real wide and up, or um, it just has to do with the contour of the maxilla. So the advancement of a maxilla and stepping the plate back is the other weird thing. Because it seems like that's wrong, because you're like, why isn't the plate stepping forward? And it has to do with the taper of the maxilla. So it's anyway, I think that's the other fixation thing that, for me at least, I was questioning whether or not it was going correctly, but it's the tendency of the case, right?
Yep.
Um, so yeah, I think that's about it for VME aspect. I think for closure, do anything
Yeah.
different? Straight W
No, not really. I mean, I think
Y?
there's always the debate of straight vestibular. linear closure versus VY and other things like that. But I still typically do nalar-based cinch, and I usually use VY more often than not.
Yeah. Yeah, I mean, I don't think it changes your decision making too much. I do know people that mess with the vestibule a little bit. I just have never really gotten into that. Because in theory, it's you could shorten the vestibule. It's just I think you might be over operating a little bit. So if there's listeners that want to tell me that I'm doing that wrong, I'm open to the idea of it. It just doesn't seem like it's all that necessary.
I mean, for me, I'm similar to you in that maybe I haven't explored it. Maybe there's something I'm missing and should utilize it. But I feel like I try to keep, as best you can, I try to put the patient's anatomy back where it was because that's how I planned it. Like, so when you start having all these moving parts and pieces, it's like, well, I planned them based off their animation, their smile from a vertical standpoint. And if I start playing with the length of the vestibule too much, then like, what point did I plan to? I planned to their native position, but now I've changed maybe how they animate or their vertical or their vestibular position, and I worry that about inaccuracy in that regard.
Yeah, and it's always just secondarily easier to do vestibuloplasties if you need it.
Yeah.
So doing that primary, I don't really, I don't know, I'm not on board with that currently, but I'm open to it. Um, but yeah, I mean, I think changing the occlusal plane, leaving them a little bit long, bar and bone for the rest of it, use an external reference, probably going old school, like how we like to do it on down fracture, bending your own plates. Those are all good tips when it comes to that. So,
Yeah, I like yours. I don't always do it. I probably should do it more of, when I remove bone in the maxilla, I keep it for grafting purposes, but I don't always collect the bone dust. And I think that's probably a missed opportunity.
oh yeah, that sounds great. Especially in segmental, it's really
Right.
good bone graft to just compress into the interdental space, you know. From above, it's just hard to get cadaver bone or whatever other bone you're using. And it is
Yeah, I
nice to
usually
see
use
cells too.
putty. I usually put
Okay.
some of that cortical stuff in there to give it some rigidity, and then I use putty. But yeah, if you can get, I mean, both from having your own, native bone versus allogenic bone, that's kind of nice to collect that. I guess I maybe should do a better job of that.
I had a case of these, you want to let me share? I think the nose management, the aesthetic nose, let's see if I can actually just show the slide. Does that show it?
I see it. Yeah.
Slide. Because the maxilla moving down, the nose is gonna the concerns that people have with the nose, which is the nose widening and the tip of the nose rotating up. With the maxilla moving down, it's basically I can't say it's impossible, but it is hard to widen the nose with the maxilla moving down. And it is hard to make someone's nasal tip rotate up with the maxilla going down. The opposite is true with impaction. Like the impaction of a maxilla will want to rotate the tip of the nose. So subspinal osteotomy is always great. If you don't do that sort of thing, just spend a lot of time taking bone out like we are showing because the tip will want to rotate and the bottom of the nose will want to widen. And so this situation, which is years ago, has a type of nose that doesn't like upper jaw surgery, right? Interlabial gap, high angle class 2, little maxillary hyperplasia, but needs the maxilla impacted. And so I don't really have any virtual planning with this. I just have pictures, and sorry about the dark 6-week photos. This is the initial picture, and this is right after. Her maxilla is going back a little bit, traditional braces, but I think her nose is okay for widening. Like it's widening a little bit. I know that
Yeah.
picture is dark, and her tips doing pretty good too. So it doesn't rotate up too much. It stays just about the same. Here she is at 6 months, and so I think generally a little bit of gingival show is nice. So she ends up pretty good. Tip of the nose, upper lip position, just facial balance. I think is still fine, even though the molars are still low class 2 Bolton discrepancies you can't really solve with jaw surgery.
Yeah, I think her nose looks
Uh,
great. I mean, I think her nose actually looks almost more natural after. Like it almost looks too narrow and not ideal in her pre-op photos. Like I think her nose is improved. Do you
Yeah,
not feel
just
that way?
but from the combination of kind of noses who people who go through jaw surgery and nasal aesthetics and whatnot, I think is a different discussion. But a tip that's already a little bit rotated up and a tip that's already a little bit on the broad side. So anyway, I think from clinical pictures of vertical maxillary excess, X-rays, like this would be someone who just planting a maxilla would make your life way hard.
Oh yeah.
So two jaw, but you see the stepped back maxillary plate. That's
Hmm.
that's very. Look at those short Delponts. Those things are backed by the second molar. I don't even know who did the surgery.
Look at that angulation on
This
there
is
too.
so old school. I know it's
Were you doing Mios there?
no joke. How do you let's get by those X-rays. So hard looking at old pictures, right? When it comes to surgery though, figuring out some of the things, VMEs are good cases to take on when you're starting out jaw surgery. So if anyone has any other tips when it comes to VME, let us know because we're always willing to learn and like figuring things out ourselves. But I think we had a shorter episode today. We back next week, or we have vacation, or are you in
Ooh,
town?
we'll have to see.
All right.
I
Yeah,
think we can make
Chris,
it happen.
sounds good. Yeah, and we have our ACOMS thing coming up here in a few months. So if people haven't, take a look. Might be hard to get tickets, but ACOMS, we are Thursday end of the day, I think. And we talked about there's other much better presenters at ACOMS.
Yeah, it's not hard to
Posix
do.
has some good topics, and going there for him to listen to I think one of his lectures has to do with sleep disordered breathing prevalence and uh, different craniofacial abnormalities. So I think that'll be an interesting topic. Um, let's see, off the top of my head, the other people talking that week. I think Fisher, is that the other one talking?
Yeah, I think Elda's
She's talking
talking.
Wednesday. Um, anyway, there's good lecturers. And then if anyone happens to be there, come by and say hi to us. We always like meeting people too. But ACOMS is coming up in February, and
Yeah.
hopefully there's good snow. So
Yeah, we'd love to see you. Bring us gifts or money. As always, we're okay with those things, and we'll see you there.
Fisher. Oh, and Ingolstadt's talking. Ingolstadt's good. And Ashish. Yeah, these are great people talking. So you're in great hands. So if anyone hasn't, look up the ACOMS winter meeting. It should be a fun one this year. So
All right, sounds good. You want to put a bow on this one? You say that's it?
I think that's it. All right,
All right,
man.
well, that was another Down Fracture podcast, a podcast for talking jaws, downfracturepodcast at Gmail. As you saw today, we do read the emails and we'll take it into consideration. Again, feel free to send some anonymous patient photos, x-rays. We'll review cases. I think that can be helpful. Maybe we should start showing more of our own, Sam. I don't know. All
Yeah,
right.
I think it's
Well,
good. Yeah, I think doing some case-based stuff will be good. It's a little bit hard on audio, describing
yeah,
it. But
for
yeah,
sure.
maybe.
All right. See you guys next time.
All
Take
right.
care. Have a good holiday if we don't do another episode before then.
All right, man. See you.
All right. See ya.